So up till now, we've been talking about how the evidence around the impact of EMMs in medication safety. We've had examples of how they're being used and what the demonstrated benefits and challenges. What we want to explore now is we want to look at the collaborative research partnerships engaged to continuously improve on our experience with EMM. So this panel is comprised of a number of very well-trained people who have been involved in this space for quite a while, but it's being chaired by Joanna Holt, who many of you will know. So whilst Ms. Holt is officially retired, what we know in healthcare is that you actually never retire, you just do lots of unpaid work instead. So you join us here. She was formerly the Chief Executive of Women's and Children's Health Australasia, Executive Director of National Health and Hospitals Reform Commission, and the Chief Executive of New South Wales Kids and Families within New South Wales Health. I'll hand over to Ms. Holt for the panel session.
Thank you very much. Right, well, I've noted that this is a bit of a tell-all type place to be in. Jeffrey's confessed to being a bit of a technophobe. I think our secretary fessed up about her medication debacle at Broken Hill. So I thought it was a really good opportunity to get mine off my chest. So I thought I'd just tell you that when I was 16 and a half, and 17, up to 17 and a half really, I worked as a casual nurse at Canowindra Soldiers Memorial Hospital. Anyone from Canowindra, Cowra? Grenfell, you promise you won't tell on me, okay? Right. So it wasn't very long ago, as you can tell. I was an assistant casual nurse, thinking that maybe nursing might be my future career, and I was asked to do a medication round. I can't believe it now, can you? Anyway, so I was doing the drops. Anyway, I can't quite remember the name of the drops, but it was the same name for the eardrops as the eye drops. So I went around putting eardrops in people's eyes. I actually only did it to one patient before I realised, but I feel much better now I've got that off my chest, so thank you very much. Right, well, it is my pleasure to chair this panel of eminent people. And to start with, I'm going to get Kate to start, but if you could possibly introduce yourself, Kate, to the audience. Thank you.
Hi, everyone. Kate Richardson. I'm an eMeds pharmacist. Been around for a long time, and I've worked across the public, private and community sectors. So I'm currently in a public-private partnership hospital, Northern Beaches, in Sydney, and we use different eMeds and different EMR to the public system. So I'm a bit of a shag on a rock, but I have watched these and want to thank Joanna and everybody here, because this is the place you've got to come and hear about them and go back and solve them. And look, hand on my heart, would very happily chat to every single one of the errors that's been presented today, including your eye drops one, and give you some solutions, because we have come up with those sorts of solutions, which are really important, and including your hazardous drugs. But it's about clinical decision support, and that's something I don't think people have quite tapped into yet. So it is a huge opportunity for EMM.
Great, thanks, Kate. Right, moving on to Alan.
Hi, I'm Alan Gardo. I'm the Director of Nursing for the Children's Hospital Westmead, and I have been part of the steering committee since we started this with the famous step wedge approach to the introduction of eMeds back in, I can't believe it was 2016. It's such a long time ago. I've been fortunate to be part of this journey along the way, and it's been fantastic to see it grow and to see the impact it's had on the hospital as well.
Thank you, Alan. And Racha.
Yes. Hi, my name is Dr. Racha Dabliz. I'm a Senior Project Officer at the Australian Commission on Safety and Quality in Healthcare. It's always a mouthful. I sit on the eHealth and medication safety team, but I am a hospital pharmacist by background, having 7 years of experience in the hospital land, and I was one of the lucky starting pharmacists who got to see eMeds grow at Concord Hospital, and what a journey it's taken. So it's great to see the journey it has taken, and so much so it made me do a PhD in that space. So nice to meet you all.
Great, thank you. Jo.
Hi, I'm Jo Root. I'm the Policy Director at Consumers Health Forum. We obviously don't administer medication or do anything like that. We've done a lot of work with consumers on safety and quality, obviously, and on digital health, and I can see people I know in the room who've done work with us. And I must say most of the findings today haven't come as a surprise to me. Particularly that people might prefer safety to free parking. I think if you went and asked a group of people in the street, do you want a safe hospital or do you want free parking? I think we hope we know which way they would go. So it's good that that research showed us that. Thanks.
Thank you. And Mark.
Thanks, Joanna. Mark Simpson, Chief Clinical Information Officer, and long title, Exec Director covering clinical engagement and patient safety. Lovely to be here. Is it confessional still at this stage?
Yes, still confessional.
Okay, well, I'll try and wrap a praise and a confessional. Look, I saw Rosemary Burke's name up in lights. Actually, Peter Kennedy should be here in this seat. He needed a roll call for this as well. But Rosemary, again, I had the pleasure of having a meal out with the Sydney team a couple of weeks ago. But my confessional was, presented to the secretary 3 years ago and had a choice of either choosing 2 district reps or 3 district reps, and I went low. And I said, Secretary, could we have 2 per district? Rosemary has still not forgiven me to this day that one particular district already had 3, then 4 CXIOs. So my apologies and mea culpa to Rosemary and Sarah.
Thank you, Mark. And Michael.
Hi, pardon me, post-COVID cough. My name's Michael Dickinson. My previous life was CIO for Sydney Children's Hospital Network, so I was heavily involved in the project with Alan. And I've moved on now to Southwest Sydney, but I guess my confessional and medication error was wrong route, wrong person. When I was a paediatric nurse a long time ago, you mimic when you're giving a child what you want them to do. And this child was quite upset. She was meant to be having paracetamol. We'd held her down to a degree, and I had my mouth open and was squirting, come on, swallow, swallow. And I put it in her mouth. She promptly spat it out. The wrong route was it went into my mouth. And when it hits the back of your throat, you automatically swallow, which is the wrong patient. So I'm not sure I put it in IMS, but anyway, we'll get on that part.
Thank you for your confession there. That's wonderful. Thank you. So you can, it's amazing how many different routes and things you can...
I didn't get a temperature, so it was all good.
Right. Well, this panel is about driving improvements in medication safety through partnerships, and my history with the Australian Institute of Health Innovation has been quite long. I've worked both within it and with it as a partner, and I think it is fair to say that all of the work they do is with the system and not on the system, but we need to get better at that more broadly and in everything we do to bring evidence to bear on any changes that we make to improve the system. So I'm going to get this expert panel to tell us how we can do that better. I'm going to start with Mark. You mentioned that you hadn't heard the word tech mentioned for 2.5 days in a group of IT people getting together, basically.
It was a first.
Talking to Mary Foley, we haven't heard much a vendor's name mentioned all day. So it has been, the whole dialogue I think has changed enormously. But how, Mark, as someone who's been charged with the responsibility of getting safe systems throughout New South Wales Health, how do you think you can scale up the sort of work that's been done here and the findings here to make sure eMeds systems or generally electronic digital systems in hospitals are, fit for life?
Well, one, attend more conferences like today. It's been an absolute pleasure. I would also like to call out 3 of the staff, and apologies if anyone else, but we've got Lillian, Rachel and Silvana who've been asking some questions. I just asked them, and look, I'll give you a flavour, and I think it would be really nice to hear from the other panel members as well, Joanna. But When I arrived, there were 7 of my equivalent role in the districts and the specialty networks. There are now 38, near 40. This month, next month, we'll have every district and network covered so that there's a senior clinical, and when I say clinical, that's nursing, midwifery, allied health, pharmacy, and medical surgical. So that's been a little bit of an uphill journey, and again, the likes of Michael and others have helped me along the way. But those are really those folk in this state who are going to be leading that next generation. But we've heard safety analytics, and again, the team, if anyone wants to know more about the next generation of thematic analysis, I think a lot of what we've done today is really understanding more deeply how to engineer, how to model safe systems. Education training, I think, has been, the last 2 weeks, is all I seem to have been discussing. And beyond, so again, some of the colleagues from Queensland and Melbourne in particular, that coaching, mentorship, understanding what it is to be a practitioner with a modern digital environment, that works for them. Also, I did call out rural formulary and its offspring, the state formulary. These are phenomenal opportunities for the state of New South Wales really to build on its history and experience, and also those staff who've really earned their spurs over the last 4 or 5 years in rolling out the eMeds and all of the experience that we've gained and garnered as a state. That will see us in good stead as well. And look, there's so many folk across the state who really are some of the best in the country, but also stand peer-to-peer with the best in the world. So it's phenomenal to have this next opportunity to show what we can do. But again, I think we heard from our panel earlier on, this is very much the care deliverers, and these are tools that fit their needs rather than the other way around.
Excellent. Thank you, Mark. Would anyone like to add to or challenge that? He said it all. Fabulous. I didn't hear, what about vendors as partners?
I'm trying to walk on eggshells. Look, there was a good comment earlier on regarding vendors and whether there's ever going to be an off-the-shelf product that would be the perfect fit. I don't think one exists. There's always going to need a degree of levels of integration, sophistication, understanding, as the Secretary said this morning, 170,000 scenarios of care deliverers who we've got to ensure that this is fit for their purpose. But also, look, the vendors have now a wholly different style of products than they were when I started this in 2003. So you can tell my duration on this. But they still are there as it's their product. They are trying to ensure that it works and it's fit for purpose. But really the answers lie in audiences like this. It's that ensuring that we are able to handle where some of the weaknesses have been identified, the likes of Joanna and others work, because no system will have all of these covered. And there's even that greater challenge. Every time we come back and do an upgrade, a change, we then find there's the potential for new potential challenges in that new digital model.
Right. Okay, thank you. Perhaps Alan and Michael, maybe Alan first. Mark's already mentioned the importance of clinicians in leading some of these digital solutions or decision support system solutions. I think one of the... It seems like Jo had this all planned out right from the start, and she probably did, knowing her, but there seems to be a lot of wonderfully ancillary findings that have occurred as a result of this. And I was very taken by the rapid feedback loops that were occurring between researchers and clinicians. Can you sort of tell me about that in terms of how it changed processes and practices and perhaps reduced further risk, and how that, partnership led to the overall success of eMeds at the children's hospitals?
Well, I think a lot of it came down to having that feedback and then being able to adapt the EMM system so that it actually reflected some of those findings and therefore sort of reduced those risks or those incidents that potentially were occurring. So I think that was important, something in perhaps writing order sentences about the types of routes that were available that have been mentioned by Magna already. So those sort of things were very useful. I also think some of the work, as Joe's mentioned earlier on today, about things like the double check medication. Now, if we hadn't had that, we would have probably gone down the route of really trying to enforce that sort of independent double checking and trying to get that working. But with the results from the double check project that was done, it's really sort of shown us that perhaps there is another route to this and there is another way to look at this. And so that's why we're sort of embarking on a new project and looking at how we can perhaps better understand double checking and how it might work. So that's another example, I suppose.
Great, thank you. And Michael, in terms of listening to clinicians or the researchers who are telling the vendor or yourselves that system changes need to be made to prevent a potential error or improve the system, how did that work?
So, if I can just go back right to the beginning with the step wedge, I think, it was, we're giving Joe credit for everything. It was probably, and fair enough, Joe, but it was almost foreshadowing the agile approach where it was that learn fast, fail fast. So as opposed to the old model of implement a whole project and at the end go, oh crap, that didn't work, or it didn't achieve what we thought it did. But it was a double-edged sword, and I've spoken to a number of the team members. For X period of months, we felt like we were on go live because you were one ward after another ward after another ward. So you're always on the run and working in that go live status, which is really, really hard. There was other issues to think about where, and I presume at work, I'm more skilled in pediatrics, but in adults, it probably is the same, where there's the transfer of patients between wards. And if you went early on with a patient that was on ward 1, and then for whatever reason we had to move them to ward 2, how did you handle that? And it added levels of complexity that wouldn't happen in a big bang approach. But from the other side of things, we could make changes, research pending, because there were certain things we weren't allowed to do to make changes because we didn't want to mess up the research. But if we as a team realised, actually, how we staffed Go Live didn't quite work in Ward 1, it enabled us to change that staffing model and have more people in Ward 2 or so on. So it was good for learnings of how we could improve processes. There were, as I said, limitations of what we could do to the system, etc., because we couldn't affect the research. But it did mean that our work practices could potentially change and were quite useful.
And were those where you couldn't change the system, was that worthwhile? I mean, the fact that you had to bear with that to get the better outcome in the end?
The exact research findings didn't happen for quite a while, as we've heard, right? But where there was some anecdotal components to say, well, that sentence doesn't quite make sense the way it is. Could we change it? Can't we change it? Will it affect the research, etc.? Now, I can't remember the details whether we were allowed to change those things. I'm sure if they were life-changing major errors, we would have, but otherwise we probably had to live with them at the time. But it did, and I think Magda mentioned earlier, there have been since, with the research coming out, the opportunities for the Macquarie Uni to provide findings to us. Now, they're not prescriptive findings. It's like, here's the 6 things or 7 things we've seen. What would you like to do with them? Now, as a CIO, it's not my job to figure it out. I think they're great ideas, but we put them through to the Medication Safety Committee and the other various medication committees and the clinical staff, and once again, clinical meaning all clinical staff, not just medicos, to see whether they were changes that they thought were worthwhile. And I'm now left kids, so I'm not quite sure whether those have been implemented yet, but it was up to us to decide as an organisation, not just as an IT person, not just as a research group, what worked, what didn't.
Yes, excellent. Okay, Joe, so consumers, we've heard a bit about parents being involved in some of the feedback and in relation to a whole range of things, including their costs of stay and so on. It gets complicated when you involve consumers and parents in things that are really complicated, like clinical decision support systems. Does CHF have any sort of experience in finding out what parents or consumers may want in terms of clinical decision support systems, and have they been involved in any way that you know of?
I think it's important to remember that consumers aren't a homogenous group. And it sounds obvious, but we did some work on, how involved people are in their healthcare, and about 25% of Australians with chronic illness aren't engaged at all in their healthcare. The rest are engaged and know a bit. I think parents of chronically ill children are a very different category, and we actually haven't looked at them. And one of the things I'm going to go back to is maybe trying to redo our patient activation study, looking for parents to just see. But I think parents want to be part of a team. So if you're going to bring in a new system which is complex, then the parents need to be considered part of the health team, and they need to be told about the changes that are going on and involved in them, and actually asked for their experience. So if you do, and I know that New South Wales Health is rolling out PREMs and PROMs, patient recorded experience measures and outcome measures, and I think medication needs to be included in that, and you need to find out from people what they are, because Virginia and I were talking, and people suddenly get their medication changed and nobody tells the carer, and the carer's been administering it sometimes for years, and then there's a new medication. So if there's a new way, if there's a new safety issue, you need to include the parents, and I think, and patients more generally. Some people want to be told. I think one of the interesting things is also whether they want to be told if there's been a mistake. And I think, again, parents of children want to know more than perhaps the average person wants to know, providing that it doesn't actually kill them or make them really sick. They probably don't want to hear about. And I know lots of doctors say, oh, don't tell them, it'll worry them. A bit paternalistic, maybe not the way of open disclosure. So I think there's a whole range of issues there about how much. But if you treat the patient and their carer as part of the team, you'll get a result.
And if I can just add to that, I know it's something that the Australian Commission is really focusing on, is that obviously there's a big focus at the moment on health literacy, but beyond that, there's also digital health literacy. So, as clinicians, we are really keen on the technology, but we need to ensure our patients and their carers know how to use the technology we're encouraging them to use. So whether that's, the My Health record, whether that's health apps. So there's definitely a need to shift more of our attention to ensuring our patients are part of that conversation. And in addition to what you were saying, is that engaging carers in those conversations is also an issue during transitions of care, when it goes from being a paediatric patient to an adult patient, and having the carer involved in that transition, but also the patient themselves, because they go from having someone supporting them with their medications to the paediatric patient potentially taking care of their own medicines, and then having them a part of that conversation about digital health really would go a long way in terms of the continuity of safe medication management.
Thank you, Racha, that's great. Did anyone else want to comment on that aspect, Mark?
Just very briefly, just to assure, so as you say, that there's no such thing as a homogeneous care recipient family representatives, but just from the senior and many of the intermediate rank committees, all now have consumer care representatives. So the safety oversight committee that I referenced, that I chair with Jim, has a consumer representative there. The virtual care work that was done during COVID has 2 reps on both, and these are relatively small committees, so that's quite a significant representation. We may want to argue, could we have more, please? But all the way down, and I think the challenge there is to ensure a balanced representation, because it is a very interesting concept of, but who can represent such a diverse population of 8+ million of our citizens here? So just to ensure that that is very much a starting point of any membership of any official committee, whether it be safety, whether it be design, whether it be engagement. So,
and I think That's all right for committees, and I could definitely argue about having only one consumer on a committee, but we won't go there. But it's more about when you involve people actually in their care, that you build that into your system, and that your service deliverers, your hospitals, your clinicians are required to demonstrate that they're actually including the people who receive care in the decision making. That's different from having them on a committee.
Yeah. Okay, great. Thank you, Jo. Kate, in your experience and at Northern Beaches, obviously the prime purpose of a medication safety system is to reduce harm, but there probably are other benefits that might accrue to a hospital or a health system or a health service from implementing, having a sort of collaborative approach to implementing a system. What's your experience?
Well, I think there's heaps of benefits. I mean, firstly, you've got to use the systems to be safe for the clinicians and make it consistent. And I think this is a really big topic where we need to collaborate more, I think, across the different systems we use, how we can ensure it's a seamless experience. So we have JMOs rotating in and out of our local health district using completely different systems. So, I mean, I just happened to be working at eHealth at the time, but I knew what decision support they were turning on and off in New South Wales Health public system versus what I'd used in, St Elsewhere's versus what we were thinking about using at Northern Beaches. And so the public sites never turned on therapeutic duplications. We'd done it at St Elsewhere's and, based on research, turned it off. We didn't turn on drug interactions, which is turned on in the public sites. And again, I'm waiting on the research to answer that question, should we turn it on or not? So these are sort of some of the conversations. I guess it's just lucky if you've been around a long time to be part of it. I think there's a lot of stuff that I would, I've been happy to share over the years. In fact, 2009, we worked out how to automatically message safe handling information on our EMMs, and we've been doing it all that time. I think you've got to delve into the background. I don't know the other systems as well, but it's finding that functionality to provide the extra layers you need. I mean, I've been looking at the paracetamol. People talk about duplicate orders on the chart. Well, actually, that's perfectly valid, but do you want to fire a block at a doctor from doing a regular order, a PRN order, and a stat rectal? Possibly just to warn them there's other orders on the chart, but you want to block it for the nurses administering. Don't let them give more than X milligrams a day. So, it's fine to prescribe possibly more than what we all think is the max dose per day, because those PRNs may never be given, but you've got to block it at the other end. So they're the sorts of bits I love getting my head into, and finding the extra layers that wrap around order sentences and order sets that give you that extra bit of safety. And I think that's the stuff it'd be great to collaborate more on and know what people are doing. Some of the alerts, I noticed that was a 0.6 gram alert. I mean, I get a lot more bullshit, I guess. What the stuff I fire at doctors is not quite as nice as that. It's, you're prescribing 0.6. Did you really mean that unit of measure? Did you think about something else? I think we've got to be a lot more, and again, using Mel and Jo's information and research inform what we're firing at people and what we shouldn't fire at people.
Yeah, great. Yeah. And any other comments from what Kate said? Anyone want to add to it? Racha, I might just ask you, the Commission's been involved in medication safety for many a year, I think. National medication charts comes to mind in my history, I'm sure in many of yours, including a paediatric medication chart, right, Madeline? Yep. But I believe you've been doing some more work recently on evidence briefings that might help this journey of medication safety. Do you want to tell people a bit about that?
Yeah, definitely. Yeah, so the medication safety team at the Commission has expanded into the eHealth and medication safety team, primarily for the reason that that's the way of the future. And so what we did is we commission medication safety briefing. So what we tried to do is bring together the literature on what we considered the hot topics at the moment. So like closed loop medication systems, double checking, which is a hot topic today. Does electronic prescribing improve the safety of administration? And we consolidated that literature, and the outcome beyond it just being consolidated literature is that it's the lessons learned, and it's a simplified, summarised version of all the literature, so that hospitals who are at the start of the journey, at the optimisation stage, or whatever stage they're at, can look at these summaries and use those summarised lessons learnt to either go and investigate further about what the literature says, or really look at their own system and be like, tick, 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 we've got that, we've thought about that, time to move on to the next issue or hot topic. So they are available on our website. They were released in 2021. And as someone who used to be a clinician on the ground, and this is why research groups like this are great, a lot of the time you don't have the time to be going out there and looking for all the literature. So it's a really great way to bring together what the existing literature is and use it to optimise practice.
Great. Okay, well, there's another resource for you. So I'm going to throw it open to questions from the audience. And I think I did hear maybe Virginia mention the word bribe before. I think Joe's got a few bribes around for people who are feeling a bit low on their sugars at the moment. So people who would like to ask a question, you may get a reward. You have a wonderful panel here. Use them. Oh, we've got lots. Have you got lots of chocolates?
It is chocolate.
I don't eat chocolate. I had a lot of afternoon tea, but I suppose just following on from what has been discussed today around hospital pharmacists and speaking to patients, and what Joe talked about with wanting information from their hospital pharmacists, getting medicines information, what's important to consumers and carers. I guess reflecting on perhaps more a question really for Kate and Racha, who's a ex-hospital pharmacist. With the implementation of EMRs and EMMs, theoretically a lot of the work that pharmacists can do can now be done not at the bedside. So when we had paper-based systems, we had to go visit the patient, flick through that chart, and all those incidental conversations that you have in healthcare, be it a nurse, doctor, pharmacist, are so valuable, be it with the patient or be it with the carer or the parent who just happens to be there, has a question, and those are so valuable. And I guess with EMM and EMRs, because you don't have to be at the bedside to do that anymore. You can do MedRec just by looking at my health record. Are we losing something from that? And are patients inadvertently seeing less of their pharmacists? And Kate, you've obviously been in Australia longer than I have, so I'd like to hear if that's something you've experienced or observed. SHPA is probably looking at doing some time in motion studies as well in the future that might address this as well, but keen to hear from yourself and the panel.
I believe there's a paper already written about that. There is actually about time spent at the bedside, and it hasn't decreased at all with EMM and eMeds. And look, there's nothing can replace conversations and clinical handover. I mean, that's just absolutely on top of everything. Look, I think pharmacists are actually possibly a little bit more time poor because they've got more opportunity to look up stuff now. It's up on the My Health record. It's on other sites, websites and stuff. So there's a lot more places they look at. And in fact, that's the thing that they find tricky, because it's all very point in time. So you have to synthesise for a lot of stuff. And even if you're talking about a frequent flyer coming back in and out of the same hospital, there's a lot of stuff you've got to synthesise there to how far back do you really go to look at all the meds they've been on. So I don't believe it's removing those conversations at the bedside. In fact, I would love to do a research study on actually giving patients what they're on, lists of what they're on, printouts of their chart even, to show their administrations, and then see what conversations come up when the clinicians do visit them. Give them access to the reference text, and maybe they can look up some questions before they walk out the door. I think that would be a really great area to maybe look at to see if what's on the chart they understand, because we describe things very differently on inpatient medication charts to what's written on that label on the pack that goes out of pharmacy. So I think there's a lot of opportunity there.
Yeah, and if I can just add to that. So coming soon, the guiding principles to achieve continuity in medication management, just being signed off by DOHAC at the moment. So one of the big things that we do advocate for is exactly what you were describing, is that having those early conversations with the patient, not 10 minutes before they're about to be discharged. I understand hospital land is chaotic, it's not always possible, but ideally these conversations would be happening quite early. And I think just following on to what you were saying about not being at the bedside as much, at the end of the day, effective BPMH, best possible medication history, can only happen if you do speak to the patient. So I think, technology is supporting effective BPMHs, but not necessarily taking us away from the bedside.
And can I just add that and Jerry knows this, but we're just about to start on a project to adapt the questions you should ask about your medicines program from Canada to the Australian context. And that's actually encouraging consumers to ask questions, patients to ask questions about the medicines and what questions they should be asking, which fits in nicely with having a conversation with your pharmacist. And I would hope EMM and things like that would actually free up your time to have the conversation. It's a tool, it's not a replacement.
And Mark?
Just to keep going on that, and see Jackie, I think it was yourself who you referenced the word it went quiet, or it became quiet. And I think that's possibly, Kate, the challenge, where it shifts from being a lot of people doing a lot of work and really hurried, trying to get all those lists of activities and tasks done against the clock. So it's not about the number of contacts and is there a reduction, but actually the environment becomes quieter. And I think all of the environments where we've really had a successful step change in the way that the care is delivered within a digital assisted environment is when it becomes quieter. And it's not around there's a significant, I think, reduction in contact points. I would hope actually it flips around, that those contact points are more focused, high quality, and very much an opportunity for there to be a discourse rather than this is what's happened to you, this is a leaflet you've got, and there's the door. So I think that's the opportunity, but challenge as well. Can we manage those model changes? Because I think this is, as we've continued to say today, this is not about the tech, it's about that environmental and modelling change, some part culture and behaviours, but I think those are the high value quality, and I'd love to have more conversations of what made it quieter.
Great. And I'm just going to do a quick survey. I've got quite a few questions lined up, but who's been an inpatient in a hospital lately, hopefully recovered and well again, or their child has, and was thinking, I'm dying to see my medical chart? Hands up. Okay, yeah, there's quite a few of us would like to do that. And where the hell is it? And how can I get out to the nurse's station and have a closer look? So, great idea.
You used to be able
transparency.
To hung on the end of your
bed. Yes, you used to be able to have a little look, didn't you? No, who knows where it is? It's not there. Right, okay, I'm going to start here. One question over here. Yes.
Thank you. Sylvana Odd from eHealth, New South Wales. So I guess my reflections on the journey of eMeds over the last few years is that there's been a lot of investment and effort put into the first, perhaps even the second generation of the eMed systems, and certainly in New South Wales we have looked at enhancing the EMR to target things like high-risk medicines. But I still feel like there's a long way to go in terms of totally optimising the use of the system to improve medication safety and to harness the insights and the amazing data within the system. So I'm keen to hear from the panel, where do the next opportunities lie in terms of improving medication safety? What do we need to do as a health system community to get there? What are those key enablers?
Okay, who would like to tackle that very small question?
Well, as Sylvana works for me, I don't think it.
Can I add?
I'll let the panel answer.
Okay, so, Michael's going to have a go.
Yeah, and from a non-clinical perspective, I've just been thinking, the research today has shown fantastically that there's a reduction in errors, right, from EMM. But none of that happens in isolation. And there are so many things that are benefits as well as improving error rates. You know, we've already said, you know, pharmacists are probably saving time because they can read the prescription. So how many things haven't we counted where we've actually given the right drug because we didn't give the wrong one because it was written wrong? We know what stock levels are. We can order in advance, so people are being able to get the drug because we knew we were running low, and so during the pandemic we could order in advance. All those things are not even thought about. But the bit that you know, you can only improve a system so far, in my point of view, from the digital side of things. What are the other causative factors that impact medication safety? I can put multiple alerts, or as Kate said, hey stupid, please don't approve this, it's not for that person, okay? If someone's tapping me on the shoulder or interrupting me or something at the time and I don't even see the message and I've clicked away, we haven't fixed the causative factor that you're not able to do it safely, quietly and in a proper spot where you're giving the medication. Or if we haven't given the JMOs on rotation the appropriate time to learn the system or learn the things because they had to keep on answering 25 pages during their training course, I don't care how good the system is. And for me, that's where EMM3 can be, is starting to look at those pieces and the whole work practice part of it, as opposed to just keeping on thinking, should we add an alert, shouldn't we add an alert, should we use strawman letters or whatever else it is. There's too many other...
Tall man.
Is it strawman? Tall man? Look, I swallowed a kid's medication, okay? You can't get everything right. So, yeah, I think that's where from a digital person, I think that's where it is, but happy for clinical people.
And I'd second those thoughts. But I think where we are now is we've got that digital maturity. So we've actually got so many people now that have looked at systems and they can eyeball and go, no, that's not right. You know, that says 7 milligram per kilo, but it meant to say 7 milligram per kilo per dose rather than per day, for example. So I think our visibility looking at systems now is infinitely better than it was 10 years ago. So that should inform future decision making and future build and future design from that aspect. But yeah, we are introducing systems that can sometimes take a lot more time, and the training is impossible. You know, if I can get half an hour, a doctor to actually give me half an hour full attention is, you know, a miracle. So they're very clever people, though. I mean, all our clinicians are very clever people, so they need to have something that is completely intuitive, and that we've made sure as much as every single little bit of that detail, milligram per kilo per day or per dose, is there, you know, and to inform, and that the calculators automatically calculate, not you have to go and edit something. I mean, there's little things like that, I think, that we have to make it easier for our clinicians. We've got to keep them safe.
Look, I would add, look, we put a lot of money in and a lot of time into the implementation and that first few weeks or month, and then it's meant to just work perfectly.
Yeah.
It needs that sustainability program as part of it as well, so that we can actually make sure that there's that continue education, continue training, continue evaluation of the system, and make the changes and have the resources for that. And from the conversations and the presentations today, I think administration as well, we need to look at that side of it. But that also brings in things like the workflow, etc., that we've been talking about. And I think someone, was it from St George, that was talking about the quality project they did, some of the aspects that they were considering looking at about the well-being of the clinician as well, that's actually doing the prescribing or the administrating as well. So I think that's something that would be really interesting to look at.
All good points. Excellent. We've got lots of questions. We haven't got very much time. We've got one up the back here that is next, and then I think Les was next. We've got one up the back here.
Yeah, I just wanted to talk, just mention about the collaboration between the public and the private. It's interesting to hear that Kate's got a great system, but it doesn't connect to the public system. The GPs have got some software, specialists have got different software. My big bugbear is that there's a patient medication list. Which one is it? Is it the GP's version? Is it the hospital's version? Is it the private hospital's version? And I would love to see for the patient to be holding a password that could get to their medication list, so that there is just one medication list. Is My Health Record supposed to do that? Should we be pushing that more and making that the single source of truth? Are we getting as much as we can from databases that could give us that?
Actually, I mean, we're very lucky in that the LHD and us, even though we're on separate systems, there is an an interim health information exchange. So we're both sending information into that so our clinicians can see what's happening at the hospital down the road. I think that's imperative. It'd be great to really beef that up. But everything's very point in time, you know, even sending stuff up to the My Health record. You know, we can send it up today, but it might change tomorrow. And again, I think it is very difficult. We need to put a little bit more ownership, I think, back into the consumer if we can. But we've got to provide them the tools as well to make that work for them. Yeah. Yep. I'd love to download that. You know, yeah.
Anyone from the Digital Health Agency here?
Hi, it's
Do you
Tracy.
want to make a quick comment on that?
Oh,
No?
okay, sorry.
Sorry? No? Anyone from Digital Health Agency? No. Okay, on Les next. Sorry?
Thanks, Jo. There's been some very appropriate discussion around partnering with parents and carers. My question is, what is the interest in the views of the panel and the capacity for direct engagement or age-appropriate engagement of children across the age spectrum? There hasn't been anything said about that.
That's in CHF. We have a youth health forum as part of our work, and that's something that they've been talking about. I think that there has been quite a lot of work, I think, done on talking to children and talking to them, and the 5 medicines thing that I was talking about actually has a children's version in Canada that is for children to ask about their own medication. So they've actually done some work on this about encouraging children and age appropriate to start talking at a 10 or 11 and even younger, and they've got resources that help them ask about their medication and understand their medication, so they're treating the child as having some agency, and I think that's probably worth having a closer look at here, but I think then you're going to get into who do you want to pay attention to, the child or the parent, and that becomes much more of an issue at that transition, doesn't it, from paediatric to adult, at what point, because sometimes that happens before the person is actually legally an adult. And, you know, particularly thinking of mental health issues here becomes a real issue, but there are others as well.
Thank you, Jo.
Hi, I'm Tracy from Taranaki District in New Zealand. We've been on the eMeds journey for about over 12 years now, and as we've implemented different systems, so automated drug cabinets, MedRec, electronic prescribing, dispensing systems, what we noticed in our ecosystem is that when you can't implement one system without it having a direct impact on other aspects of the system, and a lot of the research focuses on the one system. And as you're involved in that project, you're clearly focused on that one system. So I guess my question to the panel is, and it's a little bit in relation to yours, is how do we really truly know the impact on patient safety of the systems that we're implementing, and how do we get to the next phase on the journey?
Really good question.
Another easy one. Anybody got any thoughts on that?
I'll give a first go.
Thank you.
So the thing that I can't talk about, I'll just talk about briefly. But so the challenge within the state at the moment is that we have 2 digital systems, 7 versions of one and 2 versions of the other, that generally don't talk well to each other. So even within that frame, it's difficult. So one opportunity in this next generation is to have a unified approach so that there's no impediment. Now, I think your question is broader than that, but what about the others? And I think there was a number of other questions around that. How are we linked up with primary care, community, Commonwealth, mental health, and also that public-private? The last thing a patient or care recipient wants is that there's 3 different versions and they have to know which one it is. The challenge there was even yesterday, where presenting to the Southeastern team, they want to have, if there's a change to Sydney, their PHN is impacted across Central and Eastern. So even at that level, I think your question is very pertinent in that it's very challenging to anticipate all of those cascade effects. Here we are in my role, it's at the state delivery of care and service. Yet we have immediate impact on not only the environment of Commonwealth, private, but also at the boundary levels between ourselves and the other states. Many of our citizens move back and forth across state boundaries, and those are also cascade events that we would need to anticipate. So some of the work that Kate was referencing there, that information exchange, really is some of those opportunities. I did reference that interoperability. It's not an easy solution to connect things that don't want to talk to each other, but they can be done. But it's a layer above in the challenge. So primarily at a state level, we're going for the let's unify at the start. So let's not have to retrofit. But I think it still is very pertinent. How do we get much closer with our Commonwealth colleagues and also our interstate colleagues?
Thank you, Mark. I'm going to... One last question. I'm really, really sorry, but we're running out of time.
Sorry,
Madeline.
It's actually a quick comment on Les's point and Joe's comment about younger children's participation through providing their insights and perspectives. And the research indicates that you can actually go down to as low as age 7 or 8 in being able to obtain valid input, and that should be done and done more of. And Joe, your comment with regard to, well, whose opinion, do you take, the parent, the child, or the healthcare professional? Anecdote from when I was doing my higher degree, I embarked on doing exactly this in developing a symptom domain for an adverse event measure to use in clinical trials. And people said, oh yeah, but what are you going to do about this bit? And it was actually very interesting that the children as young as down to age 7 were able to provide valid perspectives, and they intersected to an extent with the parents and the health professionals, but in areas where they were differing, they were able to stand firm on the fact that those things mattered to them, and that, and overwhelmingly positive feedback from all 3 groups, how much they valued being asked. So I think more of that needs to be thought about and incorporated into what we do relating to medicines use generally, so not just medicine safety, but more broadly. Thank you.
Thank you very much, Madeline. Well said. Well said. I'm going to thank the panel for being very helpful in illuminating the issues around driving improvements in medication safety, and I think we've proven well that it needs to be done in partnership. There are many musical instruments that make up this orchestra, and wrapping research and evaluation around everything we do to improve the system is vital. So thank you very much to all our panel members. Can you all give them a hand?